Welcome to PharmacyToDose, the critical care podcast, where we're discussing critical care and its pharmacotherapy in a fun and entertaining manner. Each episode, we summarize the available evidence, discuss controversial issues, provide practical take-home points with a subject matter expert. I'm your host, Nick Peters. And wherever you are and however you may be listening, thank you. Now, today I'm privileged to be joined by a friend of the pod, Andrea Sikora Newsome. Now, Andrea is currently a clinical assistant professor at the University of Georgia College of Pharmacy on the Augusta campus. She's an ICU float pharmacist for the Augusta University Medical Center. Now, Andrea graduated in 2013 from the University of Georgia College of Pharmacy and completed both her PGY1 and PGY2 specializing in critical care at the University of North Carolina Medical Center. Currently, she is a KL2 scholar through Georgia's Clinical and Translational Science Alliance and is completing her Master's of Clinical Research at Emory University. And she is here lending her time and talents to discuss acute respiratory distress syndrome, or ARDS. Andrea, I really appreciate you joining me today.
Happy to be here. Very excited about this.
Now, working in Augusta, Georgia, I have to ask, have you been to the Masters? Do you like it? Or is it one of those, like if you live in New York and it's New Year's Eve, that's the weekend that you try to get out of town?
So I have been to the Masters. When I was a student, we got practice round tickets. It was the year that Bubba Watson won for the first time. So as a UGA grad, it was awesome. I will say there is kind of quite a bit of hubbub during the Masters week, but it's also a ton of fun. There's concerts and stuff like that. So I can't complain.
Okay, I actually have Masters practice round tickets this year. I'm incredibly excited. So offline, you'll have to give some of the insider recommendations for when I'm there because it's going to be a blast.
With the low prices, you can eat every one of the sandwiches, and I highly recommend trying them all because they are fantastic.
I might live on a pimento cheese sandwich diet from what I've heard. So I have no issues with that. I like that the locals also recommend that.
Absolutely.
Now, we are recording this in early December, and when this episode actually gets released, you will be hiking in Patagonia on the W circuit. So we've shifted from a sports bucket list item to just a life bucket list item. So are you going with a group? How are you tackling this hike? And you gotta let us know, where exactly is Patagonia?
So the Patagonia region is in South America. So I'll be specifically in Chile in Torres del Paine National Park. And so, it's like a 70-mile hike. So there's some days it'll be like 18 miles in a day with a 15-pound pack. But I'm going with my childhood buddy. We've been friends since we were 9, so over 20 years. She speaks flawless Spanish, so she's going to be my guide. And I'm so looking forward to it. We're going to see some mountains.
Okay, so it's almost like you're going to be with a local as well. So that's
correct.
What a blast. I mean, you're going to Patagonia, and most of us just simply wear it on our jackets or vests. So I think that's really awesome.
Yeah.
Now, Andrea, you're a book reader, and I certainly try to be a book reader. So just from that intro, and I know that doesn't cover everything you do, how are you able to make time to read so much with how busy you are?
My genuine hope is that everyone does something for at least a half an hour that keeps them sane, most days of the week. And I can't say that, I'm perfect in that or anyone can be truly perfect, but I hope that you're spending a little bit of time doing something you love. And so, reading is definitely one of my things. I will say I'm not much of a TV watcher, so I guess I get some time back because I don't watch a lot of TV. But I'm currently reading What If by Randall Munroe. He's the NASA engineer who writes these cute little comics. So today his thing was that if you are learning something for the first time today that everyone else knows, if you do the math, it means at least 10,000 other people are also learning it for the first time, which I thought was pretty interesting.
I'm a big fan of that. That's great because it just truly changes the perspective. Like a lot of times when you learn something, you think that you're behind the curve, right?
Correct.
That everyone's ahead of you. But realistically, you may be beating 9,999 other people.
That day, you got it.
Now, before we get into talking all things ARDS, I have something to announce, and it needs to happen when you're on the podcast. Now, yikes. Okay, that sounds like bad news. It's actually good news. I feel like we should do like a precursor here. So what we want to announce is that Andrea and I will be co-leading a quarterly book club for all listeners and friends of the PharmacyToDose podcast. Now, This won't change anything with the podcast itself. The content, when it's released, all that's going to stay exactly the same. But the mission of this book club is to create a digital platform to discuss books that promote both professional and personal development for the critical care healthcare professional. So we will not be doing any New England Journal, medicine articles or journal clubs. No one's going to have to hear an impact factor in these book clubs, I promise. So it's just meant for books that help expand your development. So there will be the plan right now is that there will be a group on Goodreads, which is like a kind of website for book lovers to unite. And it's more of like a traditional message board so people can interact without being there exactly in the moment. But then we'll also have kind of Twitter chats for real-time discussion with the hashtag PharmacyToRead. Now, we will announce the 4 choices for the first book on the next episode, and then we'll kind of have a Twitter poll or accept submissions via email so you, the listener, can help pick this first book that we get to read. Andrea, this is going to be great. I'm extremely excited. What are your thoughts on it?
Oh, I'm definitely super hyped about this. I think this is going to be a ton of fun. Ironically, at UNC, they do a roast at the end of the year of the residents. And so my second year as a critical care resident, one of the things I got roasted on was actually a critical care book club. So this is really coming full circle for me, and I am really, really pumped.
So all of the Emory University, where I did my residency, they do a roast as well, and they are a little more harsh with their superlatives and things. So on air, I can't repeat any of those, but I'm glad to hear that's a trend elsewhere, and we're kind of going full circle here. So the idea came for Andrea to help because if you follow her on Twitter at all, you're always posting really good quotes, pictures of like summaries of things that you've read. So I think it was kind of a natural pick. So I think this is going to be great. Yes. Definitely. We're still finalizing things. So send Andrea or I kind of your thoughts. And we will definitely incorporate that as we get moving forward. But we anticipate that this would go live starting in 2020. So that's kind of the process or timeline that we're thinking right now. So the real reason we're here today. Today, we're talking about acute respiratory distress syndrome, or ARDS. Now, we're going to get into all of the research and progress that's been made. But Andrea, what's kind of the history of ARDS, and why are we talking about it today? Why is it important?
So to me, ARDS is almost a microcosm of all of critical care. It's highly complex. You see it fairly frequently, so relatively common. It's got pretty high mortality. It's also hard to define. It's hard to study. The literature is conflicting. And yet every day as a clinician, you're faced with how to take care of these patients. And so to me, that is why we're talking about it. From a historical perspective, I would say that it was Ashbaugh and colleagues. That was in the 1967, and they published this 12-patient case series, and they described this rapid development of respiratory distress with acute onset of tachypnea, hypoxia, and a loss of compliance. And interestingly, there's a pretty fun little read you can have about it where they say how it really happened, and they talk about how the two authors were together and they're like, what does this knob do on the new ventilators? And they're really discovering PEEP for the first time and how well PEEP works. And it got rejected because this was completely against standard of care to use PEEP. And that's maybe another thing that I love about ARDS is there's actually multiple things, and I'll try to point them out, that we first discover in ARDS as being good, and it turns out that they're a good idea in other areas of critical care. So PEEP will be one of the first of those. And so I'd say maybe in like 1994, the American European Consensus Conference, or AECC, got together, and it kind of created this definition. It talked about severe hypoxemia using the P to F ratio of less than 200. They had bilateral infiltrates on chest x-ray, and then you couldn't have any evidence of cardiogenic pulmonary edema. So it couldn't be because of your heart.
So were they playing with those? So they were playing with those knobs on an actual patient. This wasn't like the ventilator came and then they were trying to see what everything did. They did the very man sense, which is rather than look into and try to figure out everything before, we're just going to dive right in and figure it out later. That's what they it's a funny little article of like them looking back and 30 years, these two people back in the day. So that was really neat. I should also say, in terms of mortality and epidemiology,
It's about 10% of all ICU patients have ARDS, about 25% of all mechanically ventilated patients have ARDS. And from there, if you have severe ARDS, about a 50% mortality rate. So it's something you will see, and it's definitely a high severity disease. So
it's kind of humbling that you're already talking about people that are extremely sick on the ventilator. Now you're talking about when you get the worst case of this, it's 50-50, chance of survival.
yes.
That is really important, and why there's so much research and everything that's gone into ARDS, since that first report of it. Now, that definition or criteria that was created in 1994, when that happened and as time progressed, there was definitely some criticisms there. So is that still what we use today to help diagnose ARDS?
No, it is not. So some of the criticisms you talk about are there's a pretty high rate of inter-observer error on reading a chest X-ray. This hypoxia criteria of the PaO2 to FiO2 ratio can be altered by what the ventilator settings are, which includes things like PEEP, but also the FiO2. And the tough part is it's not a linear relationship. So if you are using FiO2, you can see different ratios. And they also found it has a pretty low specificity for ARDS. So in 2011, they got together and created the Berlin criteria. And so this is the onset within 7 days, bilateral opacities consistent with pulmonary edema, P to F ratio, and then you have the stratifications, and then on a PEEP of 5. And I will say that there is also plenty of editorials and funny commentary on the Berlin criteria not being amazing either.
Yeah, let's dive into a little bit about that. Like, what are some limitations or criticisms to the Berlin criteria? Because it was last updated in 2011, and at this point, right, basically we're on the fringes of 2020. That's 9 years ago. Lots changed in critical care.
Yes. So one of the things you'll hear about is the Kigali modification. And so this has to do with the fact that, we're talking about criteria that are based on having a ventilator. If you're in other parts of the world that do not have ventilators, how are we diagnosing ARDS? The other part too is we used to really put a high emphasis on there could be no cardiac source of this pulmonary edema, but it turns out that heart failure patients can also have ARDS. And so how are we evaluating those situations, right? And then probably one of the most interesting papers that came out was that there was a report, it was about 700 autopsies that they did of patients with ARDS based on the Berlin criteria. And when they did the autopsies, only about 50% showed what they call diffuse alveolar damage, which we thought was like the pathophysiology of ARDS. So now it turns out that either we don't know the pathophysiology or we don't know the definition. And so this it reminds me a little bit of I love Ocean's 11, so that is the one movie that I can quote and like talking about. But the Saul is asking Brad Pitt when they're getting ready for the heist and to get into this casino. And he goes, I've got a question for you. He says, say we get into the cage and through these security doors there and down the elevator we can't move and past the guards with the guns and into the vault we can't open and without being seen by the cameras. To me, that perfectly captures what is ARDS. We don't know how to define it. We don't really know why it happens. We don't really know why what works actually works. We don't have great epidemiology because, again, we can't really define it. And a lot of the studies are negative. So it's a wonderfully uphill battle, but it's also a ton of fun for that reason, too.
And then just like you said, like it's once you start looking into it, you realize the things we thought we knew, we do not. And so it's almost like, building upon itself. For anyone who, by the way, as an aside, anyone who hasn't seen Ocean's 11, you need to get out there. That quote is so perfect because even at the end of it, you think he's done, and then someone like interjects and adds something else. He's like, oh yeah, and that. Like it's very, very perfect.
Yes.
So have we been able to, identify any, common causes or risk factors or, things that we can, try to get ahead of for these patients that in a disease that has this kind of high mortality?
Yeah. So I think probably one of the best studies is the Lung Safe study. It's about 12,000 patients in a cross-sectional study. I think came out in 2016, and that's where I was citing those the 10% rate and the 25% of mechanical ventilation. But they also identified different risk factors and things like that. So generally, risk factors we think of are pneumonia. That's 30 to 50% of the cases. Then you move into non-pulmonary sepsis, aspiration, and trauma. Some other specific risk factors are like age, non-white race, and some genetic variants. But what's fascinating is that, like, while age we know is a risk factor, it doesn't necessarily confer extra mortality. So, and then you get into there's a lot of people that get pneumonia, but not everybody gets ARDS. So we know there's a genetic component, but I don't think we have a great feel for that just yet. So, yeah.
I mean, the pathophysiology kind of going into, you mentioned genetics and that probably plays a part. And that would make sense because, the pathophysiology of ARDS, it's one of those things to me that is just fascinating because of all of the changes that happen throughout the time course and how, an intervention early might help, but if you do that same intervention late, it might only not help, but actually hurt. So kind of walk us through the kind of typical ARDS time course, leaving those outliers out that all of us, I think, have seen when we've been in practice.
Sure. So as you're saying, ARDS can definitely be broken down into different phases. So you kind of have the acute phase or the exudative phase of ARDS, and this is characterized by that diffuse alveolar injury and capillary endothelial injury. And there's one description I loved, and it describes these neutrophils adhering to the pulmonary capillaries and boring these little holes through the basement membrane. And then when you have these little holes in the basement membrane, these large plasma proteins seep through into the interstitial fluid, which then disturbs Starling's equilibrium, and you get this diffuse pulmonary edema, and that can reduce gas exchange and lung compliance. Somewhere in the mix, you get neutrophils and T cells that are also migrating into this inflamed lung, and they're also amplifying the damage. At some point, you're going to want to ask me why are all these immune cells acting different, and I don't have a great answer for you. The underlying cause for that altered behavior is not well described. So at this point, your alveolar epithelium has two types of cells. The type 1 cells are the gas exchange surface. They're like these flat little plates, and they're what take the brunt of the damage. And then you have type 2 cells, which also get damaged as well, but not as much. And they're the ones that produce surfactant and the progenitor cells. And at some point, you'll move into the proliferative phase, which is like the repair process. It's considered essential for recovery. That's when you get the reabsorption of the fluid. There is a fibrotic phase that people talk about that has been associated with prolonged mechanical ventilations. It's also sometimes called the recovery phase. And in terms of time course, I'd say the acute phase we feel pretty comfortable with, maybe the first 7 days. And then after that, you start to see the other phases kicking in.
So the acute phase, I think, is something that is, very evident to see, right? It is the patient that either comes into the ED that's already needing like 100% oxygen, or the person that you're weaning and everything's going great, but then overnight aspirated, and then suddenly their FiO2's up to 90% 2 hours later and all those things, right? So thinking about like the pathophysiology, outside of that acute phase, are there any ways for kind of us as pharmacists or the critical care team to kind of know how that patient, if the patient is going through like through those kind of different inflammatory phases, or is that something that we don't really have a good grasp on right now?
I would say that we do not have an amazing grasp on that. I think biomarkers and stuff like that are going to be part of that answer. But that is one of the tough things, is that it's very difficult to diagnose, but about a 50% lack of recognition, according to one study, and it's very different to prognosticate, to really know where the patient is. So P to F ratio is like probably one of the best things that we have going for us. And as we've already said, there are some limitations to that.
So it sounds like it's a disease state that's a lot more common than we may think right now. It kind of affects our sickest patients. So when we have these patients that have ARDS, what would you say are our treatment goals?
So when you take a holistic approach to ARDS management, I really think you come up with the three classic principles of critical care. And to me, those are the treating the underlying cause. So if they have pneumonia, you would give them antibiotics. You're going to provide supportive therapy, which is going to be like mechanical ventilation, fluid management, stewardship, and then don't harm the patient in the process of the first two. And really for ARDS, it is the bread and butter is the supportive care right now. We do not have a therapy that targets these kind of maladaptive immunoresponse. We just don't have that at this point. So it's largely supportive care.
Those principles sound so great. It almost feels like there are probably pulmonary critical care like fellowships that make the fellows get that like tattooed on themselves, right? Because those three principles I think you could apply kind of across not only critical care but almost medicine in a sense of like that is universal. I love those. I think I'm going to steal that probably, but I'll definitely give you credit.
You can definitely. I stole it from somebody else. One of my main mentors once told me that. When I was at UNC, and I was like, that is beautiful. And I have it in almost every one of my PowerPoints at UGA. The students laugh at me sometimes about that. So
I like
welcome
that.
to it.
I know I've given a presentation. I hesitate to say taught because I was a critical care resident teaching it to Emory pharmacy students. I'm not sure who was more nervous to be there that day, but I remember when you talk about ARDS, like say you have a 2-hour lecture, you're 90 minutes in and you might not have mentioned a single med yet. Right. And so It's just a very, when you're thinking of classic, pharmacy type of lectures, this is one that breaks the mold, which I think is a good thing. I think that sometimes as pharmacists, not only is it very good to understand pathophys and how all these, machines, equipment and things work, but also sometimes the best med is no med at all. And that's,
correct.
I think that's a really good thing. Now the hallmark here is supportive care. I think the biggest piece of that supportive care puzzle is mechanical ventilation. So if you wouldn't mind, I want to make sure everyone is kind of on the same page with kind of our most important non-pharmacologic ARDS intervention or treatment. So if you wouldn't mind kind of giving us like a 3 to 5 minute, I know we have like tweetorials. I think we'll do a podtorial here and just kind of talk just basically, about some of the ventilator modes and maybe what some of that common terminology is. So that way, when we kind of get into things a little bit later, we'll all understand what you're talking about. And then no one's going to have to stop and immediately Google things, or at least not right away.
That sounds great. So, to get on my soapbox for a second, I think having a basic understanding of mechanical ventilation is really important for any pharmacist that works in the unit, because this is actually one of the best ways you can to monitor the drug therapies and to monitor how the patient is doing. So I think if someone once told me they checked their email during when the respiratory therapist was talking, and I was like, oh, please don't do that. That's pretty important for this type of patient. So, and
a quick aside, I'm just going to interrupt for a second.
Yeah.
Please, nobody be checking email when members of the team are talking, especially like that just sounds, imagine if we were talking and like you look over and the nurse is, checking out Facebook or something. That's not what you want to see. Yeah.
Exactly. So mechanical ventilation is a life-saving intervention for these patients. And so the trick that we're trying to do is to oxygenate these patients, but to do so without the things that harm a patient about our interventions, going back to our three principles of critical care. So we have to be concerned about volutrauma, which is basically volume that's going to be kind of hurt in the alveoli, barotrauma, which is the pressure, and then oxygen toxicity. Creating those free radicals. So, and to this day, probably one of the most unequivocal trials of showing benefit in ARDS and really in critical care medicine was by ARDSnet, and it's the low tidal volume ventilation study that showed that 6 cc's per kilo times ideal body weight versus the standard. And it had this striking, like almost 10% drop in mortality. They had to end it early because they were so surprised. So again, this is a really important intervention. And I will again stress that anyone with a calculator can take the tidal volume and then divide it by the ideal body weight to just see kind of where your patient is.
And it's always good to kind of check in on that because all of us are human. And there's plenty of times where you think someone is on 6 cc's per kilo, but unfortunately, because there were 8 admissions and things, we calculated on actual body weight. So it can kind of just be a way for everyone to kind of double check those types of things. So I that's something that I always do. I always encourage students as well. So I'm glad that you support that as well.
Oh, for sure. So globally, a ventilator mode is a type of respiratory support that's being provided. And if you want a classic attending to med student question, they'll say, what are the three things that define a mode? And the answer is going to be the trigger, the target, and the cycle. Or if they're a bit more seasoned, they'll say trigger, limit, and cycle. And so what this is referring to is what initiates the breath, that's the trigger, what the goal of the breath is, that's the target, and then what terminates the breath and goes to exhalation, and that's the cycle. And your options are time, pressure, or volume. So you've been so long since you've taken a breath, that's the time you have a breath. Or you reach a certain volume, then that'll cycle your breath for you. From here, I think the workhorse of many units is probably pressure regulated volume control, or PRVC, and other classic modes are volume control and pressure control. So what this is referring to is what is actually being controlled or targeted for that mode. So in volume control, you're targeting a very specific tidal volume. That's how big your breath is. And so if you target that volume, then the pressure is variable. What makes PRVC so interesting is you can use a decelerating flow pattern, and it makes the pressure be constant, but also allows you to target a specific volume. And so they'll say it's a breath-to-breath mode because it changes every single breath, but within a range. So you get to have this target pressure and target volume. So that's why you'll see it so often.
And the volume for us, like the tidal volume, like when you take a big breath in, like that is a larger tidal volume, right? Correct? All right.
Correct.
All right.
Yes, bigger breaths.
Exactly. I like some layman's terms because in an audio format, some people may be listening like, oh gosh, I'm hearing all this. So I like to just try to break it down as in you or I trying to hold our breaths here. So I'm sorry for interrupting.
No, that's true. And and to be clear, like when you take a big breath, like what you just did, that could easily be 800, 1,000 cc's. And it's pretty interesting to look at when you do 6 cc's per kilo, maybe around 400 cc's, how small that actually is. It's pretty interesting.
Did you ever have to, when I was a resident, we got hooked up to a practice ventilator and you see what actually low tidal volume is? And I'll tell you what, that is not very easy to feel like you're getting good breaths because it is significantly smaller than I think what you or I take on a volume on a daily basis or a breath basis.
Yeah, and that is an incredible experience if you can ever get hooked up to the ventilator modes and see the different ones. But yes, that was very eye-opening how small that breath was. Fun facts are that we'll talk about neuromuscular blockade in a second, but in those studies, they used volume control, that specific mode. And I think that's important that when we're talking about neuromuscular blockade, that we're using the mode that actually went with the study. There are some advanced modes like airway pressure release or APRV ventilation, HFOV or high frequency oscillatory ventilation. There's some new fancy things you might hear about like neurally adjusted or proportional assist ventilation. And those are studies, if you go looking, clinicaltrials.gov, you'll see that those are being evaluated too, but beyond the scope for here. So probably the three main things are the FiO2, the PEEP, and the tidal volume. So the fraction of inspired oxygen, 21% is what we're breathing, maybe a little lower in Denver. Anything, 40 is a pretty standard number. Anything over 60, you're likely to see oxygen toxicity. Tidal volume, again, that's just it's a volume number. It's in milliliters. It's just how big is the breath when you take a breath in. PEEP is kind of funny. It's positive end expiratory pressure. So if you think about it, when you breathe out, and you can guys breathe out with me, if you want, you can force out a little bit more air, and it feels a little weird. That little extra air that you forced out is actually your PEEP, and that's a natural thing. And the best way to think about it is like when you blow up a balloon. You ever blow up a balloon? The first few breaths are so hard, and then you finally get to that kind of magical breath, and it's super easy. So your body has figured that out for you. So it provides you that natural PEEP, so it's easier for your alveoli to blow up.
Isn't it funny that when talking about PEEP, I cannot explain it without actually doing the breath example? Because I'll try to say it, and it's like, okay, let me just do this because I think it'll be easier to understand.
Yes, absolutely. I love doing that. And students are always like, wow, that's amazing. I never thought of that. Let's see. I don't know. What else you want me to talk about?
Well, do you have any favorite, like Michael Cawley is a dual PharmD respiratory therapist. For anyone who is looking for more information on ventilators or things, definitely take a look. There are some really good review articles. There's also a I'll post it. I can't remember the name of it offhand, but I think it's called The Ventilator Book and the Advanced Ventilator Book. I think it's by Dr. William Owens. It's a green book. I can't remember exactly, but there's a lot of good kind of resources for those who are kind of looking for more information. Now, quick tangent here, because I really can't help myself. So does the ventilator mode that we have patients on, should that affect the sedation that we use or our sedation targets?
So people like to say this, and I don't think that there is if you are on X mode, you have to have X, amount of sedation. I have seen a patient on APRV, which is a really interesting mode. It's an inverse ratio. So the whole time I'm talking, I'm exhaling, right? And in this mode, they flip it around. So I spend like only a second exhaling and the whole time inhaling, which is really different. And supposedly people don't like this. I have watched someone do a crossword puzzle on APRV. They waved at me. They were doing well. They needed APRV. They were on no sedation doing a crossword. So I do not think so.
And that's the mode. That's the mode that historically people have argued for deep sedation, correct?
Yes.
Because it's kind of that strange mode different to how we normally are lung physiology.
Right. And what's like a neat fact about APRV that they have found is that, you have the lung flow dynamics, and I'm not going to pretend that I am really good at physics, but there are some interesting papers that basically show that spontaneous ventilation on APRV actually has more recruitment and is better for the lungs than non-spontaneous ventilation. So to paralyze someone or to overly sedate them, you may actually be negating the value of APRV, which is really fascinating.
Wow, that actually really is. Okay. Yeah. So I couldn't help myself, but I'm glad I couldn't, because that was extremely interesting. I like that. That's always my thing. I always try not to. I try to keep the same kind of sedation targeting goal regardless, but I just had to ask.
Yes.
So
I love talking about vents.
So if we had to probably rank non-pharmacologic interventions, kind of what we do within critical care, I got to say that my probably favorite is prone positioning. Now, normally patients, right, they're sitting supine in their hospital beds. They're kind of on their backs like we would normally do laying on the couch. Now, prone positioning involves a patient laying kind of on their stomach or abdomen rather than their back. So how does laying on your belly help this, really severe disease?
Great question. So it's kind of interesting to think about, but the lungs towards your back they're bigger in the back than they are on the front. So when you lay on your back and you kind of get all gravity and all the kind of gunk and edema going down, it actually will. You have the most blood flow there, but now you're impeding gas exchange. So prone positioning actually improves what they call VQ mismatch or ventilation perfusion mismatch, which is really interesting. And again, it's non-pharmacologic. Of course, the problem with this is now you have someone on their belly that you're trying to manage. But the Provisa study is a pretty amazing study by the French. It was a 28-day mortality. It was like 50% less than in the standard of care group. It's like 16 versus 32.8% difference, which is pretty incredible.
If you ever kind of on rounds or with a preceptor and they're asking you for trials that actually reduced mortality in critical care, start with ARDS, because that's about 80% of them. And then like everything kind of, because you mentioned the Perceiva, the prone positioning study, and then the title, that's where, a lot of these are. So there's a lot of big benefits, but why do you think that it is? I guess, why can it be challenging, or why, if we're going into units, that we don't see 3 to 4 people on their bellies, all across the country?
Yeah, so there are definitely some logistical challenges to this. And I mean, even one as simple as actually flipping them over. Recommendations, they want 3 to 4 people to flip them over, so just finding those people, getting them all in the same place. You have to be actually prone for like 16 hours a day, they found. So it's not just like, you get to spend half an hour and you're good to go. You'll hear people say, I don't know if we can feed. Do we need different sedation? They're concerned about pressure ulcers. But at the same time, to me, 16 versus 32 in terms of a percentage mortality reduction, I feel like we should be taking on these. I would think of this as challenges, not barriers.
Mm-hmm. and line placements as well, right? Depending
Yes.
on where that is. And
Absolutely.
I've been to two places. So the one at a previous health system that I worked at, we did not have any specialized beds or anything. So the critical care team did all of the moving. They say 3 to 4. I think that's probably on the lower side. Whenever I've ever done it, I mean, it is a all hands on deck. It's something like, it seems like 6 to 8 patients
Wow.
or people are in the room there. And this was a French study, and I think depending on where you go in America, the people that you may be lifting from your back to your belly, right, the demographics may be a little bit different here in America. And so what another health system does is they have the rotaprone bed. And as far as know, I don't think there's any other options available. But what you do is it's this specialized bed where you hook the patients in, and you have all of these like special padding to try to prevent pressure ulcers and things. And then it is a bed that actually does the flipping for you. It's got to be, that it has to be expensive, and that's probably why it's not everywhere, but potentially a solution if you're having problems kind of getting that implemented. Because it is a really important intervention. And I know I could speak for myself, and you probably the same. I've seen it to where people are on the brink of death, and you put them in prone positioning, and within 12 hours they're back to 40% P5, and we're weaning them, almost giving them a sedation trial and things. So it is remarkable, some of the changes that can happen.
Yes.
Now, another intervention that could kind of be made for just refractory hypoxia or other kind of respiratory issues like a respiratory acidosis would be the use of neuromuscular blockers to help achieve paralysis. Now, within ARDS, that evidence used to be much stronger. However, that kind of may have recently changed. So where do we stand now with neuromuscular blockade within ARDS?
That's a great question. So, historically we had the Accurasis study, or Accurasis. I always think I'm pronouncing it wrong, but they evaluated cisatracurium. It was a 48-hour trial, and they used volume control. And they did a bolus and then a continuous infusion, no titration, no train of 4 monitoring. And when they did accrued mortality, they showed no difference. But then they did an adjusted mortality for like the SOFA score and P to F, and they did see a statistically significant difference in mortality. And so you saw a lot more neuromuscular blockade. Then the Rose trial just came out this past year, and they basically, to the best of their ability, basically redid that study only in kind of modern times. And now what that means is that you have neuromuscular blockade and deep sedation versus no blockade and light sedation. And they saw no difference in 90-day mortality. And so the question becomes now, should we be using it or not? I personally, I think that neuromuscular blockade is not something you should do for everyone. I definitely think you need to reserve it for the most severe. However, a couple of comments I have on the Rose trial are that they excluded patients that were previously on neuromuscular blockers. And this was like 700 patients or something that they excluded that are potentially the patients that would benefit the most from this therapy. They also enrolled patients in 8 hours versus 16 hours in the Accurasis study. And so in modern times, there's a new kind of phenotype of ARDS that they call rapidly improving ARDS. And so there's a possibility, and those patients seem to be very different than our classic ARDS, but they probably captured some of those in the Rose trial. And I would agree, someone with rapidly improving ARDS does not need to be blocked. But if they were, I think that might have muddled the results a little bit. So where are we? Don't use it in everybody, but probably someone does benefit.
And like previously receiving neuromuscular blockers could be you got RSI in the ED and got paralyzed with something, correct? Or was it they received an infusion? I mean, I don't think it really matters because frankly, but just more curious.
Yeah, so my understanding was a lot of those patients were already on an infusion. And so basically what you're saying is that somebody prior to them getting enrolled in the Rose study thought they would benefit from neuromuscular blockade. So one editorial, I loved it, said, this is likely not random, that those patients got it. And so, the point is we probably took out the sickest patients that they're like, wow, this patient is so sick. We need to be very aggressive, immediately starting blockade. And now we're not even looking at those patients. And I think that that's really unfortunate that we don't have more data on that group who probably would have benefited the most.
Now, I think I got a couple of follow-up questions, but we have to establish something here, because I think before this Rose study came out, I think there were two clear sides of where people stood with neuromuscular blockade within ARDS. And if Chris Droege, is a previous guest, is listening, we've talked about this before, and he was on the right side of this. But the one side of this was that, like, you wanted to follow the results of the Accurasis study, right? You followed the study design, you used the larger fixed doses. Because like the 37.5 milligrams, like when you average that out, that is significantly higher than like our classic weight-based cisatracurium that we would use. So that was kind of the one side. Now the other side was, okay, maybe they just benefit from paralysis. Let's go ahead and start like we normally do, titrate to a train of 4, maybe BIS. We're not going to get into the monitoring of it. But where did you stand before the study came out? Were you on the larger dose, or were you on the more conventional side?
I was on the larger side.
I was too. It was a hill I was going to die on. Like I fought hard for it. And then this study came out, and I can't tell you how many of my intensivist colleagues gave me a very hard time, because I always fought this. But you brought this up earlier, and it's a point I think we need to make, is that we love getting the results of these studies, but then we don't apply them the same way that they did. Because it's like there are small studies that says cisatracurium may like reduce the amount of interleukins and cytokines and things. So it's like maybe there was a benefit to that dose. So that's where I stood. I couldn't believe when this came out that it showed that none of that really helped, and it really makes me question all of the other studies that I love and if that is going to maintain or not. The more we know about ARDS, the less we know is where this stands. But I'm glad that you were on my side, kind of the literature side of things, regardless if it was positive or not.
I like to think of myself as a purist. I don't think I'm always, but I do try to be a purist when I can.
Okay, so I think there's a couple follow-up questions here. So if you decide to go down the paralysis route and you're using neuromuscular blockade, should you use cisatracurium? Because the pharmacist, the value pharmacist comes here and saying, well, that's probably significantly more expensive than another agent. Is it an agent specific effect, or is it a class effect? So where do you stand on this?
So I am a believer that my primary belief is that you should use the agent that was studied in the study. And so we know that cisatracurium works, and I do not know if something else works. I do think there is probably some type of class effect, but I am unwilling to say that without the data. But I also know that cisatracurium, you're right, does have mechanistic, it makes sense because of its other anti-inflammatory effects and stuff like that. And maybe that data is available for other neuromuscular blockers, but maybe that is another study. Is there some other type of effect that's going on besides just ventilator synchrony?
And cisatracurium, it undergoes Hoffman elimination. It's it's like a very different medication. So it would make sense that might have effects that some of the other kind of classes of neuromuscular blockers might not have.
Yes, but yes, I am definitely a believer. And when we created our neuromuscular blockade protocol at AU, we use cisatracurium. So
again, I think this question would have been a little more difficult to answer before this Rose study came out, but I think something that always came up. Now I'll put myself out there and say I'm much more on the prone side of things now, but prone versus paralysis versus kind of doing both. I think that was before this study came out. That was a question or something that always came out, especially maybe in areas where logistically proning might be challenging.
Again, I think the purest answer, when you look at the proning studies and the neuromuscular blockade studies, usually they were on both in fairly high percentages. And so the question becomes, is it one, the other, or both that are mechanistically, is there a synergistic effect that's going on? I will say, unfortunately, I don't think the institutions I have worked at have maximized our ability to prone. So I have, in practice done a lot more just neuromuscular blockade. But I do think that's really interesting. And well, if we get to the ECMO studies, they'll talk about how in the Eolia trial, like 90% of the patients were prone and on neuromuscular blockers and stuff like that. And I think that's because that's what we're considering to be the optimal care for those patients.
Now, you stated that kind of the treatment goals of ARDS, it focuses around supportive care. And I think one of the studies that kind of embodies this supportive care kind of concept the most is the FACTT study from 2006, kind of focusing on conservative fluid management in patients with ARDS. So I know our previous guest, Anthony Hawkins, is smiling, hopefully, as he's listening to this, talking about fluid stewardship here. But when you look into kind of the study algorithm, it's pretty in-depth. So my question for you is, how do you actually apply the findings of that FACTT study to your patients, or just generally, like just patients in general with ARDS?
I definitely do not follow the FACTT protocol. I do admit that because it is very complex, and even I have to go back and really follow the little flow chart to look at it. But the way that I look at it is, to me, it kind of you're turning on a dime, And so the second that you're saying that patient is hemodynamically stable, you're perfusing effectively, I think you have to almost immediately say, can we start diuresing, and can we get this patient, at least fluid even or fluid down, potentially, depending on where you're at. So unfortunately, we do not have a protocolized method for use of this trial, but I think it needs to be one of those questions where, to me, almost the second that I feel like we're not talking about hemodynamics, I want to be bringing up, are we going to diurese this patient?
And that's something to clarify here, is like the conservative fluid management is once they're out of that shock phase, like you mentioned. Like, I know we probably have some cowboys who might recommend otherwise, but generally speaking, if they're still on pressors, we're still talking about all those things, tough to recommend a diuretic in most cases. In most cases here. Now, go ahead.
Yeah. I was going to say, one of the classic, to me, pharmacy interventions is, given that your patient's on pressors, you can still be looking at a patient with ARDS for how can you minimize fluids? Can you concentrate antibiotics, concentrate pressors? To me, that's an easy intervention for this patient of, like, maybe you're not going to actively give a loop diuretic, but you can at least be mitigating the other stuff that you're giving. So yeah, shout out to fluid stewardship for sure.
And then even antibiotic stewardship, right? Maybe getting rid of those unnecessary antibiotics that gets rid of the liter of fluid for your vanc or whatnot there. So before the ROSE trial came out, I would argue that probably the most controversial pharmacotherapy treatment option was the use of corticosteroids for ARDS. I know that sigh kind of says it all. So why is this such a controversy?
To me, it's a controversy because you've got kind of this one investigator team that's done a majority of the positive studies. And when it was repeated by not that investigator team, in the New England Journal, they found that there was no difference. And then if you do it in late stage ARDS, you're actually harming the patient. And so then you can say, well, we'll look at the exact study and say that's when harm is, right? This exact time point. But then, as we were discussing, I already was hemming and hawing as what is early and late. So am I harming someone before that point? I just don't know. That, to me, makes me very nervous. To me, steroids remind me of when I got my husband a really nice drill, and all of a sudden he's pulling out the drill for like hanging a picture on the wall. And it's because it's like a cool toy and it kind of works, but at the same time, it just seems wildly overkill for what's going on and maybe not even the right tool. And that's how I think about steroids in ARDS.
That is the most perfect analogy. That's so great. I'm like almost crying over here laughing. That's so great. And the I believe it's from Tennessee, but it's Dr. Maduri, correct?
Yes, the Maduri protocol.
And so he is, and physiologically, it kind of makes sense a little bit, right? Because you mentioned it's this acute inflammatory early phase, and what is corticosteroid, right? It is that anti-inflammatory. So I understand kind of the concept there. And I kind of agree with your opinion. Now, if you have a provider or a team that just insisted, right? I have an old provider who used to say, you didn't get a true shot if you passed away and didn't get doxy or steroids. So a little tough to argue there, but so say, you're working with that provider and they just insisted, what regimen would you use or recommend in these patients?
So the last time that someone asked me this, I said, well, I don't recommend it. And they said, well, what would you do? And I said, well, as I said, I don't recommend it. Like, you can do what you want, but I personally am not involved in this recommendation. And then they kind of pushed me. And so then I just joked with them. I said, what about hydrocortisone 50Q6? Because they were also septic. And we kind of laughed. So I really would prefer not to. Do you have a favorite?
So that was a research idea that I kind of wanted to do, because a lot of times these patients are in septic shock and they'll be getting hydrocortisone. And so to see the effect of, patients with septic shock and ARDS, the effect of, I was going to do like, length on the ventilator per se, not necessarily mortality, but compare those two, because that's generally what I see. I've never recommended the corticosteroids for ARDS, but sometimes you'll naturally see some of those mineralocorticoids because they have concomitant shock with them. But I think the majority study did I think it was a weight base, like 1 to 2 mg per kg of Solumedrol. And then it was a long wean. That's like a 28 to 35 day kind of taper there. So it's, in terms of like steroid stewardship, it's not great there.
No, definitely not great. Yeah. So I think that the whole team laughed at me, and I think we ended up doing hydrocortisone, and I was like, okay, I can keep moving, I suppose.
Literally like wiping your hands away, like as they're talking to you, like I'm wiping my hands of this. I did not want this.
Yes.
So many drugs or kind of interventions have been researched and kind of eventually failed for the treatment or management of ARDS. Some of them may initially have had like a positive, maybe a retrospective or a small study, and then eventually you get bigger and the results weren't so promising. So I mentioned we're recording this in December, so we'll kind of maybe refer to these as like the ghosts of ARDS past, right? So what are some therapies that we've maybe tried but didn't go as well as we maybe hoped?
Yeah. So there's a lot, and we've got steroids, we've got albuterol, we've got statins, we've got prostaglandins, we've got surfactant. Those are just the ones that are coming off the top of my head right now. And a lot of them did not show a difference. And so, but one of the things I kind of want to go back to real quick is like even the FACTT trial. And we're just like, we almost skipped over the FACTT trial. We're like, yeah, of course we're going to do fluid stewardship. Of course this makes sense. Not only was it in ARDS, but it's in everywhere else. But they actually didn't see a statistically significant mortality difference. But then you look at what they wanted, and they wanted this like enormous mortality difference, like 10% or something was how they powered their study. But when you really look at it, it was like a 3% mortality difference, and they said it wasn't significant. But I'm just going to put out there that for me, a well-timed Lasix dose providing a mortality benefit of 3%, I'm interested in. And so, it turns out with a lot of these ghosts of Christmas past, I'm definitely curious about when we look at how are we powering these critical care studies? Is a 10% mortality difference reasonable for a statin?
No.
Yeah, exactly. And so there's actually some really interesting work coming out. It's like Calfee and colleagues, and they actually did some phenotyping of ARDS and then reevaluated some of the statin studies and actually did find a mortality benefit in patients that had more of an inflammatory phenotype, which I think is very interesting and very hypothesis generating for how we should be evaluating ARDS as a whole.
So do you have kind of like a contrarian opinion to statins in ARDS? Is that where you're kind of leading us towards here right now?
I certainly am not going to stop your statin if you have ARDS and you have a statin on board. And, to me, the problem right now is I don't have a great way in my unit to assess the inflammatory phenotype for ARDS. But in terms of reevaluating some of these studies and maybe pulling out that rapidly improving group that seems to do fine if you just do good mechanical ventilation, they just get better. I don't think we should be studying them for statin therapy. But I think there's probably a group that does benefit. So I suppose I have a contrarian opinion. I'm not putting it on everybody right now, but if you told me there was another statin trial happening, I would very happily read it.
Is it one of those where you don't discontinue it, but if you see it on a home med list, are you asking to get it put back? That's kind of, you're not getting new starts per se, but like if someone had a previous indication, you're popping that guy back on. Or you're trying to. Okay.
Yes. I'm a deep believer in statins, and statin withdrawal is a thing. And the fact that if you have statin withdrawal in the unit, you can see adverse effects and stuff. So yes, I will definitely restart it.
Now, so are there, we've kind of tried all of these, and then the things you mentioned with these, with kind of the ghosts of ARDS past, is like a lot of them initially had small things that were positive, right? Like that initial statin study actually was positive. Kind of switching gears from meds to ventilator modes, but like the oscillator, the HFOV, that first study was extremely positive, and then the previous ones were not only they were not positive, and then they became negative. So so it's one of those, you hit the nail on the head earlier when you're saying that we're kind of hitting the tip of the iceberg, and just when you think you know something, it cuts away 70% of the knowledge that we thought we knew.
Right.
So So we've kind of tried all of these therapies, right? We've prone them, maybe we've paralyzed them. We've got them out of the shock phase. We're doing conservative fluid management, and now, we're doing low tidal volume, all the ventilator support. We're trying everything, and they're just still not improving. So I think really we kind of have one chance left here, and that's kind of ECMO. So, right now, and I think this is probably the aspect of this that's probably progressed or changed the most with this, but what is the role of ECMO for kind of severe ARDS?
That is the $1 million question. So there was the Caesar trial that came out, and it showed no difference, but a lot of people had problems with this study because it was a very heterogeneous ventilation strategies that were used. And then they would randomize patients to receive ECMO, and they would go to an ECMO center, and then they never actually got ECMO. And so there were some issues with this study. And so the Eolia trial came out in New England Journal earlier this year. And once again, unfortunately, did not see a difference in mortality. But there's a couple of interesting kind of caveats to this. So one of the things that happened was that they did JAMA came out in JAMA they called it a Bayesian analysis. And so Bayesian analysis is a statistical methodology using what they call prior probability distributions. But essentially, it uses prior data to decide what is the percent chance of a benefit. So it'll say something like there's a 50% chance of a 4% reduction. And then are you willing to roll that dice? And so the Bayesian analysis actually did show some benefit for ECMO. And then you can get into, that's an interesting rabbit hole with the many editorials. And so there's one person that, how did they describe it? They basically said, well, using a Bayesian analysis is basically just me using my own opinion anyway. So why would I bother to do this analysis? But I think probably one of the most interesting things about the Eolia study was that the patients in the control group were treated with probably the highest standard of care in terms of what ARDS management is. They had low tidal volume ventilation. They were prone. They were on neuromuscular blockade. They had very specific protocols. And so I think you can maybe rest in comfort that if you're doing everything right by a patient, maybe you don't need ECMO, but at the same time, if you're not doing some of those things, maybe ECMO is the right answer. There's also there was some crossover in the Eolia study, and so when you looked at the patients, there were like 35 patients that crossed over from the non-ECMO to the ECMO category, and 15 of those they survived. And so someone said, well, the crossover was used, you actually would see a significant difference, with ECMO. So, what is the role? I think ECMO in a previously healthy patient, so like I still remember my 25-year-old college kid with the flu and ARDS.
It's the flu always, isn't it?
Yeah,
it's just awful.
Right. And they put him on ECMO, and he was going to die. And they put him on ECMO, and he lived. He walked out of the unit. And I think for that kind of patient, there's a benefit. But I think when you start looking at older patients, a lot of comorbidities, it's hard for me to make that argument. Or harder, I should say.
And I think, too, there's just so much variability that goes into ECMO. Like having a positive ECMO trial and then, taking that and implementing that in, across the country is probably just really, really challenging compared to like a lot of these other things can definitely be challenging, but maybe not as complex as something where you're literally bypassing, one of the holy trilogy of the organs, the lungs there. So, but I ask that because, I know there are centers who they have such a well-tuned ECMO machine that they might bypass a lot of that other stuff. And if someone is severe ARDS, they might hook them up on VV ECMO right there and not even try to prone or paralyze them. Whereas, I think in most cases, you're going through the other stepwise approach. And then if those fail, then you're going to ECMO.
Absolutely. Absolutely.
So in your opinion, what would you say are kind of some of the biggest research areas in regards to the management of ARDS? Or maybe not areas, but maybe like are there a few key studies or things that we should be keeping our eye out for?
I think the holy grail of ARDS research certainly remains identifying a disease-modifying drug, and finding something that would truly alter that disease course. And I think there's some stuff looking at gene therapy right now is pretty interesting. I think the most feasible and interesting research that's coming out is really evaluating response by different phenotypes and different endotypes, and the use of biomarkers to kind of be able to differentiate those. Because I think that we have some therapies that really do work, and we're just not always 100% sure of who to implement those in. So to me, I think that's the stuff that gets me the most excited when I see my table of contents comes through. When I see something about that, that's definitely what I'm picking up to read more about.
So what you're saying is that, and we're in the trust tree here. We've established that already. So I need to stop skipping over the pharmacogenetic sections in the table of contents is what you're telling me, because hand up, I do that. I do. But you're saying for ARDS, I definitely need to pause, and be perusing those. I can do that.
Yes, I will admit that if I see one more pharmacogenomic study about warfarin, that is something I also skip over pretty quickly. But for ARDS, I am very intrigued as to what's coming out right now.
So we've hit on tons of such great stuff here, but a lot of it didn't really talk about meds, like very much at all. So what would you say is kind of the role of the pharmacist with regards to ARDS management? Without having, a lot of, say, key medications that are those kind of disease modifying agents that you said, what can we do?
So to me, ARDS patients benefit from high quality critical care management. So, when you're thinking about what is a critical care pharmacist doing, you're hoping they're doing fast hugs BID, you're hoping they're doing antibiotic de-escalation and fluid stewardship and all those types of things. I think there are some fun particulars to ARDS. One is, again, that more aggressive fluid management. I think that's a good thing. Pull out a calculator, check the tidal volume yourself. I know one time I did, and they asked me, and I said, hey, this is kind of high. What's going on? And they're like, oh, we just can't get them to do anything else. And I was like, well, let's play with their sedation. And so, of course, we all are very good at pain, agitation, delirium. We can manage that. And so we came up with some good tricks, and then they could be on low tidal volume ventilation. One of my favorites is that, we allow what they call permissive hypercapnia when we ventilate them, which means that basically we know that they're going to have a little bit of elevated CO2 because of our ventilation strategy. You don't need to freak out. It's not a big deal. Occasionally some residents like, we should do some Diamox. And I say, no. We're good. We don't need that. I think understanding the ventilator modes with regards to neuromuscular blockade is very helpful. But then just do what pharmacists do best, which is manage the meds. And I think when you do that and you provide that high quality interventions, that is going to benefit an ARDS patient the most right now.
Be a medication expert. That's what we're there for. You're exactly right. Well, I'll tell you what, this may have been the most fun that I've ever had having an ARDS topic discussion or any type of discussion on it. This was absolutely fantastic. Andrea, I appreciate not only for your time and knowledge that you just passed along, but I think some of us may remember I'm also a quote guy. So I love sharing those, almost just as much.
Good.
Now, where can the listeners find you? Are you active on any type of social medias or anything?
Yes, I am active on Twitter. My handle is @Andrea Sikora. So please feel free to follow me. I try to put up some good book reviews and what other random things I think are interesting for the day.
Yes, and then there will definitely be more to come on the book club. This is the first announcement, so very, very excited for more of the Pharmacy to Read information coming. So Andrea, thank you.
Thank you.
Another huge thanks to Andrea Sikora Newsome for taking the time to join us today. And definitely also want to give a massive thank you to you, the listeners, because this podcast does not exist without you. So please send me feedback, both positive and negative, as well as any guest or topic ideas via Twitter or Instagram at PharmacyToDose, that's T-O to dose, or via email at PharmacyToDose@gmail.com. And if, this is feedback not only for, the episode and topics and things, but also on the book club. So if you're excited or if you have ideas for books or things, please send info to us, give us a shout out on Twitter or Instagram. We'll be really excited there. So on our website, PharmacyToDose.com, you'll find the show notes that include background reading, guidelines, some articles that Andrea referenced in this discussion, and much, much more. And honestly, I would genuinely love to hear from each and every one of you. So until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.